This podcast was developed by Katie Gergelis with the help of Dr. Karen Forbes. Katie is a medical student at the University of Alberta. Dr. Forbes is a pediatrician and medical educator at the Stollery Children's Hospital and the University of Alberta. Learning objectives. By the end of this podcast, the learner will be able to, number 1, describe normal acid-base physiology and compensatory mechanisms for acid-base disturbances. Number 2, interpret an arterial blood gas, or ABG, using a standard approach. Number 3, list common causes of metabolic acidosis and metabolic alkalosis. And number 4, describe in general terms the acute management of acidosis and alkalosis. Let's start with a case. You are a third-year medical student working in the emergency department during your pediatrics rotation. Tommy is a 2-year-old boy presenting with symptoms that seem consistent with a viral gastroenteritis. His parents describe multiple episodes of emesis and diarrhea for 2 days. He has failed oral rehydration, and you clinically assess him as being moderately dehydrated. When you review with your preceptor, you both agree to send off a blood gas to look at Tommy's metabolic status. Now, before we interpret your patient's blood gas, let's start by reviewing the basics of acid-base physiology. The human body does a pretty good job of keeping serum pH regulated within a narrow range. pH is normally maintained between 7.35 and 7.45. Despite this tight regulation, things can sometimes go awry. When pH is below 7.35, it is termed acidosis. When pH is above 7.45, it is termed alkalosis. We often classify acids in the body as respiratory or metabolic. Respiratory acids, such as carbon dioxide, are controlled by respiration, whereas metabolic acids are not controlled by respiration and instead need to be neutralized or excreted from the body. We will come back to this point later. When the acid-base balance is shifted, the body has a number of mechanisms for compensation: organic buffers, respiratory compensation, and compensation at the level of the kidneys. Let's look at each one. First, organic buffers are usually able to keep the pH within the normal range by donating or accepting hydrogen ions. Organic buffers include bicarbonate, hydrogen phosphate, and protein anions. However, the extent of this compensation is fairly minimal. Second, let's look at respiratory compensation. If the pH is too low, the respiratory rate can increase. This reduces partial pressure of carbon dioxide in the blood. Conversely, if pH is too high, the respiratory rate can decrease, thereby increasing the partial pressure of carbon dioxide. These respiratory compensations occur quite quickly. But how does altering the partial pressure of carbon dioxide affect the pH, you might ask? Carbon dioxide and water combine to form carbonic acid, or H2CO3, which dissociates to bicarbonate, or HCO3-, and hydrogen ions, H+. This reaction is at an equilibrium in the body, so the direction depends on the concentration of reactants and products. For example, when there's plenty of carbon dioxide around, the direction of the reaction favors the formation of bicarb and H+, thereby lowering the pH as a result of increased H+. However, when there is less carbon dioxide, the direction of the reaction favors the formation of H2CO3, which uses up the bicarb and H+, thereby raising pH as a result of decreased H+. Thinking back to the lungs and respiratory compensation, it makes sense that acidosis triggers hyperventilation and alkalosis triggers hypoventilation. Third, the kidneys can also help compensate by generating bicarb and secreting H+. When bicarb is above the normal range, we say that there is a base excess, and when bicarb is below the normal range, we say that there is a base deficit. Unlike the quick response in the lungs, renal compensation is slower. It involves the generation of ammonia, as well as reabsorption and secretion of bicarb and H+. However, the full details of what occurs in the kidneys is beyond the scope of this podcast. In broad concept, an acidosis triggers the kidneys to make more bicarb and remove H+, thus increasing pH into the normal range. On the other hand, alkalosis triggers the opposite. Now that we've reviewed the basics, let's have a look at Tommy's blood gas. The pH is 7.25, The partial pressure of carbon dioxide is 36 millimeters of mercury. The bicarb is 22.5 millimoles per liter. The sodium level is 135 millimoles per liter. The potassium level is 4.5 millimoles per liter, and the chloride level is 105 millimoles per liter. Given this blood gas, let's go through an approach to its interpretation. You might be wondering, how do we identify and measure acid-base imbalances in our patients? Clinically, the ABG and serum electrolytes are used to analyze a patient's acid-base status. While we will be focusing this discussion on the arterial blood gas, one important thing to note is that except in the critical care setting, we do not often do an arterial blood gas in pediatric patients. More often, we will substitute with a capillary or venous blood gas, which are much less invasive to obtain. The key difference in these alternate sample types is the interpretation of oxygenation, which is not very accurate from a venous sample. The interpretation of the acid-base status from a VBG, or venous blood gas, follows the same general principles as an ABG. Number 1. The first step for interpreting an ABG is to ensure that you have the correct results for the correct patient. It sounds simple, but it really is important. Number 2. Next, you look at the pH. If it is outside the normal range, is there an acidosis, pH less than 7.35, or alkalosis, pH greater than 7.45? Number 3. Next, turn your attention to the partial pressure of carbon dioxide and compare it to normal values, which is typically 38 to 42 millimeters of mercury. Is the partial pressure of carbon dioxide outside of the normal range? If it is high, is pH low? This would be a respiratory acidosis. If the partial pressure of carbon dioxide is low, is the pH high? Then this would be a respiratory alkalosis. Number 4. Now look at the bicarb and compare to normal values, which is normally 24 to 30 millimoles per liter. Is the bicarb low? Next, look at the pH. If the bicarb is low, suggesting a base deficit, and the pH is low, then it's a metabolic acidosis. Is the bicarb high? Next, look at the pH. If the bicarb is high, suggesting a base excess, and the pH is high, then it's a metabolic alkalosis. When trying to classify the acid-base disturbance as respiratory or metabolic, I like to think, does the pH align with the level of carbon dioxide, or does the pH make sense with the level of carbon dioxide? If the answer is yes, then the primary problem is respiratory. If the answer is no, then the problem is primarily metabolic. Number 5. Then determine if any compensation has occurred. If the acid-base disturbance is acute, compensation likely has not kicked in yet. But if the disturbance is more chronic, you will note changes in the ABG that reflect compensatory mechanisms. For example, with a metabolic acidosis, respiratory compensation triggers hyperventilation, which lowers the partial pressure of carbon dioxide. With respiratory acidosis, metabolic compensation triggers ammoniogenesis, increasing H+ secretion into the urine and increasing bicarb production and retention into the blood, causing a base excess. Number 6. The next step only applies if there is a metabolic acidosis. In order to further classify the acidosis, you should calculate the anion gap. Anion gap compares the amount of measured cations to the amount of measured anions in the body. We do this to look for the presence of unmeasured anions in the body. If you think back to your chemistry knowledge, we are interested in these anions because they represent the conjugate base of an acid in the body that is contributing to the low or acidic pH. So, a large or wide anion gap is a surrogate marker suggesting that an acid was added to the body. To calculate anion gap, you use the equation of sodium concentration plus potassium concentration minus chloride concentration plus bicarb concentration. Or, sometimes this equation is simplified, where anion gap equals sodium concentration minus chloride concentration plus bicarb concentration. Normal anion gap is considered less than 12 millimoles per liter. Now, let's apply this approach to our patient's blood gas. Number 1, we've double-checked to ensure that we are interpreting Tommy's results from today's visit to the emergency department. Number 2, a pH of 7.25 is below the normal range, so Tommy has an acidosis. Number 3, the partial pressure of carbon dioxide is close to the normal range, so it's unlikely to be a respiratory acidosis. Number 4, bicarb is below the normal range. There is a base deficit. This suggests that Tommy has a metabolic acidosis. Number 5, there may be some respiratory compensation or hyperventilation, as the partial pressure of carbon dioxide is at the lower limit of normal. And number 6, the anion gap is equal to 135 plus 4.5 minus 105 plus 22.5, which is equal to 12. This is a normal anion gap metabolic acidosis, or NAGMA. Let's go back and learn more about acidosis. Once you have calculated the anion gap, consider, is it a normal anion gap metabolic acidosis, or NAGMA, or is this a wide anion gap metabolic acidosis, or WAGMA? So let's start with NAGMA. If the anion gap is normal, this indicates that there is an intrinsic problem with regulating H+ in bicarb, either due to reduced H+ excretion, or more commonly, due to increased bicarb loss. There are 2 sites where this can occur: the GI tract or the kidneys. In event of GI losses of bicarb, if the kidneys are functioning well and the GI losses are chronic and mild, renal compensation can often work to prevent acidosis. However, in the setting of severe GI loss, the kidneys may be unable to compensate quickly enough. This is what happened with Tommy. He was losing lots of bicarb in his stool, and renal compensation was unable to keep up, so he developed a metabolic acidosis. The NAGMA could also be due to renal problems. For example, an inability to make bicarb or excrete H+, such as what is seen with renal tubular acidosis. There are different types of renal tubular acidosis depending on where the issue is within the tubule. However, this is beyond the scope of the podcast. Next is WAGMA. The wide anion gap indicates that there are unmeasured anions in the blood, i.e., acids that have been converted to their conjugate base. This is the reason for the acidosis. A common mnemonic used to remember possible causes is mud piles. M is for methanol or metformin. U is for uremia. D is for diabetic ketoacidosis. P is for multiple things such as propylene glycol, paraldehyde, or paracetamol. I is for multiple things such as iron, isoniazid, isopropyl alcohol, or infection. L is for lactic acid. E is for ethylene glycol. And S is for salicylates. Hopefully the patient history and clinical context will help direct you about the possible etiology of the WAGMA. In pediatric patients, lactic acidosis, DKA, and salicylate ingestion are the most common causes of WAGMA. Some clinicians find the mnemonic CULT easier to remember and more applicable to pediatrics. The K stands for ketones, the U is for uremia, the L is for lactate, and the T is for toxins such as salicylates, paracetamol, and alcohols. Now, let's consider a different scenario. Tyler, a 3-year-old boy, has come into the emergency department after getting into the medicine cabinet and eating some of his parents' pain relief medications. The results of his ABG indicate a metabolic acidosis. The pH is 7.29. The partial pressure of carbon dioxide is 33 millimeters of mercury. The bicarb is 14 millimoles per liter. The sodium level is 140 millimoles per liter. The potassium level is 4.2 millimoles per liter. And the chloride level is 110 millimoles per liter. Now, let's use the approach to classify his metabolic acidosis. The anion gap is equal to 140 plus 4.2 minus 114 plus 110, which is equal to 20.2. Thus, Tyler has a WAGMA, likely due to salicylate ingestion. One of the next steps would be to obtain a plasma salicylate concentration to confirm. So far, we have focused on metabolic acidosis. Let's turn our attention to alkalosis. If you work through the approach to acid-base and determine that there is a metabolic alkalosis, then there are two things to consider. One is what started the alkalosis, or how was it initiated? And two is why is the alkalosis persisting, or how is it being maintained? So initiation. There are many possible causes for metabolic alkalosis. Thus, it is easier to start by thinking, was there an addition of bicarb or a loss of H+? For example, bicarb can be added due to an ingestion or a citrate administration, such as a blood transfusion, and H+ can be lost due to emesis, H+ being shifted into cells, as in a patient with hypokalemia, or renal loss of H+. Renal losses could be a result of hypovolemia, thiazide or loop diuretics, or mineralocorticoid excess. All of these processes lead to increased sodium reabsorption in the distal tubule and ultimately increased H+ secretion into the lumen and therefore loss in the urine. Maintenance. In a normal and healthy patient, the body will be able to respond to a metabolic alkalosis and return the pH to its normal range. Thus, a continual process must be occurring that perpetuates the alkalosis. Again, we can categorize the possible etiology into two categories: volume dependent or volume independent. Volume dependent. This means that the patient has low intravascular volume and the kidneys are stimulated to reabsorb sodium. As previously mentioned, this can lead to H+ loss. The other option is volume independent. If the problem isn't low volume, then something else must be going on. This could be a mineralocorticoid excess, which stimulates the sodium-potassium ATPase, or low GFR, leading to an impairment in bicarb excretion. Now, consider another patient. Travis is a 4-week-old infant brought in by his parents with non-bilious vomiting that has progressively increased over the past week. He vomits forcefully after he feeds, and he seems hungry and irritable through the day. On exam, Tommy is severely dehydrated. He is 200 grams below his birth weight. On physical exam, you palpate a small mass in the right upper quadrant of the abdomen. His lab work shows a pH of 7.58, partial pressure of carbon dioxide of 42 millimeters of mercury, a bicarb of 38 millimoles per liter, a sodium level of 137 millimoles per liter, a potassium level of 3.1 millimoles per liter, and a chloride level of 85 millimoles per liter. The high pH and high bicarb, which indicates a base excess, tells you that this is a metabolic alkalosis. Why does Travis have a metabolic alkalosis? Recall that he was brought in after several days of vomiting with poor intake. The initiation of the alkalosis was likely due to the loss of H+ from vomiting. The maintenance is likely volume dependent and related to his dehydration. As his kidneys are trying to retain sodium, H+ is being lost. Moreover, Travis has a hypokalemic, hypochloremic metabolic alkalosis, and his clinical picture is suspicious for pyloric stenosis. Next, we will move on to learn about the general initial management of alkalosis and acidosis. Of course, the definitive management involves identifying and treating the cause. Let's start with acidosis. Please note, IV bicarbonate administration is controversial. It is generally reserved for very severe or chronic acidosis, or in the critical care setting. So, respiratory acidosis. Assess and stabilize the patient's airway and breathing, i.e. using a bag and mask ventilation, intubation, or bronchodilators. Reverse any sedative medications slowing respiratory rate. For metabolic acidosis, some etiologies require urgent and specific treatment, such as insulin for DKA, fluid resuscitation for lactic acidosis due to shock, and activated charcoal for some acute ingestions. In the context of renal failure, dialysis may be required. Now let's go to alkalosis. Respiratory alkalosis. The respiratory rate needs to be slowed. For example, this could include reassurance, anxiolytics, or pain control. For metabolic alkalosis, again, treatment is aimed at the etiology. Some simple measures might include reducing vomiting, stopping a diuretic or citrate administration, correcting hypokalemia, or giving IV fluids. Back to the cases. Number 1. When Tommy came in with metabolic acidosis due to diarrhea and dehydration, we would want to correct his fluid deficit with IV rehydration. His acidosis will resolve once his diarrhea settles down. Number 2. When Tyler came in with a metabolic acidosis due to ingesting his parents' aspirin or salicylates, the initial management may include activated charcoal. Supportive care and alkalization of the urine are important in the treatment of salicylate ingestions. Number 3. When Travis came in with a metabolic alkalosis due to vomiting, we would want to first correct his fluid and electrolyte deficits. Surgical management would be the definitive treatment if we confirmed the diagnosis of pyloric stenosis. In summary, thank you for listening to this podcast. I hope you now have a better understanding of acid-base physiology and how we can use that to interpret blood gases in the context of our patients. You should be able to, number 1, describe normal acid-base physiology and compensatory mechanisms for acid-base disturbances. Number 2, interpret an ABG using a standard approach. Number 3, list common causes of metabolic acidosis and metabolic alkalosis. And number 4, describe in general terms the acute management of acidosis and alkalosis. Next, check out the companion acid-base case on pedscases.com. Here you can test your knowledge by working through clinical scenarios, interpreting lab results, and answering practice questions. Thanks for listening.